I'm in outpatient physical therapy here at Kentucky Clinic, and I see neuro patients, only neuro, I don't see any ortho. And I've been a PT for like 18 years now. So my main focus is balance and gait training. I see a lot of people with Parkinson's, stroke, MS, and ataxia, so different like spinocerebellar ataxia, those type of patients. So back in, I think it was April, I did a presentation for K&I, and Dr. Yamasaki did a presentation prior to me about different gait abnormalities with the neurological patient, and they wanted me to do one on outcome assessments and measurements. Now keep in mind that these are ones that I use in the outpatient setting, so they may not be possible to be used in this form for inpatient, but there may be pieces and parts that you can look to see if you can look at components of the dynamic gait or components of the timed up and go, or you can do a lit review and see what other outcome measures. I'm a big fan of outcome measures. I think that's the only true way to know if the patient's making progress. It can be beneficial not only for the PT, because you know if you're on the right track and if you're looking at the right things, but it can be motivating and inspiring for the patient to see that they've dropped a few seconds in the time it took for them to complete a timed up and go, or that their balance score has actually improved by 5 points. So that's one reason I really like to use outcome measures, and then living in the outpatient world, I have to use outcome measures so that insurance will continue to pay for their visits. But even in inpatient, in rehab, because I used to work at Cardinal Hill, sometimes we found it challenging in that type of setting to always do outcome measures. But there are some things to keep in mind in terms of if there's a certain hallway or a certain stretch, or if you measure things out in a typical room, so that you already have your setup wherever you're at, or a setup that you can quickly go to, and you don't have to always measure 10 feet, or you don't always have to measure a 25-foot pathway, that you can incorporate. And I like to think of my outcome measures as being a part of the treatment. When we're doing the outcomes, they're working on sit to stand, they're working on turns and walking. When we're doing the Berg balance test or the 30-second chair stand test, we're working on neuromuscular re-education. So I try not to think, I've heard some people at other places say, I don't like to take the time to do an outcome measure because that takes away from treatment time. Think of your outcome measure as a part of your treatment. They're doing balance, they're doing walking, they're doing turns. So it's a great way to incorporate it, and it will hopefully give you some good data. Also, I like to use my outcome measures to guide my treatment. That's really another big reason why I use outcome measures. I can look at that dynamic gait index that we do, or the functional gait assessment, and I know what components of their balance with walking is the problem. So I can hone my treatment in on just those components, and I know that they're good with, maybe walking with head turns, but they're not good with walking in narrow base, or they can't walk backwards. And so that's where we're going to concentrate our efforts. So I feel like it helps me streamline my treatment strategy for that patient. So there's just my thoughts on outcome measures. Feel free to chime in if you have a question at all. We'll keep this really informal and try to leave time for questions, okay? So I'm going to talk about balance screening in the outpatient clinic setting, which I know is a different setting for you guys. I didn't modify the presentation for this, since they wanted me just to come and do this one. We're going to talk about how to identify patients at risk for falls. And I know that's a big thing in inpatient. It's a big thing in the outpatient clinic now. That's K&I, the Kentucky Neurology Institute, has started an initiative to recognize patients when they come into the clinic for the neurology appointment, if they are a falls risk, and if so, refer them to therapy, which has been great. So we're trying to do same-day referrals or within 1 to 3 day referrals for patients for balance, retraining, and education about falls. But we're still working on our tools and how to do that assessment in the physician's clinic. We're going to talk about different balance screening tools that I commonly use to identify patients at risk for falls, and what are the next steps. So you've identified someone as a patient with falls risk, and for you guys, they're maybe going home. What do you want to make sure that you include on your recommendation for discharge would be a next step for you all. And then to identify assessment and treatment of balance and gait, which is pretty varied. So when we look at addressing falls in any setting, a multifactorial approach is best. So we're taking the patient's input, the caregiver's input. We're using our assessment skills and our outcome measures. We're also looking at medication review. I I had a patient just yesterday. She was having a horrible time with her balance when I was seeing her, and it got some better, but then she found out she was diagnosed with another disease, and they were going to start treatment with that. She had to have surgery and start treatment. And I saw her yesterday. She looked fantastic, and she's like, look at me, I can stand, I'm fine. And what had happened was the treatment, the surgery and the treatment for this condition that she was recently diagnosed for allowed her to come off of seven blood pressure medications. 7, it's a lot. And she said it's almost miraculous how much better her balance and dizziness is. And that makes sense, but that wasn't something that I could fix, but that's why medication review is important. Of course, there wasn't anything at that time until she got that diagnosis that we could do about that, but it's just important to know what's going on and what might be causing dizziness and balance issues. And then having a relationship, maybe talking to the physician or the pharmacist if there's anything else that they could try. I'm talking about the patient's physical activity and how being active is so important. Many patients, you guys know this, when they are fearful of falling or they feel like their balance is off, what do? They like stop moving, don't they? They like stop doing things that they normally do, and then what happens? Their balance gets worse, and so then they go to do one little thing and they fall. You're right. And so this whole cycle of fear of falling, not moving, worsening balance, falling, that just keeps, it's a vicious cycle. So we have to break that cycle with introducing them to physical activity that they can safely do and how important that is to keep them from losing their balance more. Talk about home environment and safety and how that's a big issue. I know you guys probably run into this, like how many of our older patients, like they love their throw rugs, right? They love those rugs. Or small pets, finding out if they have small pets at home. Dogs or cats that get underfoot can be a problem. Not that they need to get rid of that, but maybe that's part of what we need to do in treatment is to throw novel things in their path so that they have to learn how to get out of the way or how to switch their balance or change and do a step strategy. So those are all things to think about, as well as doing the whole patient education thing. So in our clinic, we have initiated a fall screening through K&I. This is the screen self-report, and it's from the CDC. The CDC has a great program called STEADY, which I think stands for Stop Elderly Accidents, Deaths, and it's like a severe type of title, but we call it STEADY. So this is what the patient fills out when they come into K&I. Such questions as, have they fallen in the past year? Have they ever been advised to use a cane or a walker? Do they feel unsteady when they're walking? And I think that's important to ask the patient, because before Kate I was just asking, have you had any falls? And if they say no, then they're good, they're not a fall risk. But do they feel unsteady? Do they steady themselves by holding onto furniture? Or are they worried about falling? I've had patients, and you probably have too, that they are a falls risk, but they seem to do pretty well in the clinic. They're not somebody that you would quickly identify as a falls risk. But then when you ask them about falling, they say that they're really concerned about it. They're really worried about it. And that's an indicator, because like we talked about, that vicious cycle of the fear of falling leading to decreased movement, decreased activity, leading to more falls. So asking them if they're worried about falling. So those are just some different questions. If they score, a yes may be worth 1 point. There's 2 of them, the first 2 that they're worth 2 points. If they score 4 points or more, that indicates that they may be at an increased risk of falls and should elicit a referral to therapy for me or to another clinic. And I'll talk about how we're doing that process. Some balance assessments, if they send them to me, then I'm going to do a quick balance assessment. And these are some of the examples. These are ones like the 30-second chair stand test might be one that you'd be able to do in the inpatient setting. And we'll look at that. The 4-stage balance test is also one that doesn't require equipment or a lot of space, as well as the timed up and go. That you kind of have to have it set up. I don't know what the rooms look like, so I don't know if you have room to do that. Or if you do a modified version, which technically wouldn't be a tug, but what if you had them just get up, walk 5 feet, turn around and come back, and you use that as a standard measure across the board with your patients, and you use it as an indication of their mobility, just their personal mobility. That could be a study, like a typical hospital room, a timed up and go test. You guys could totally do that. All right, so we'll talk about the 30-second chair stand test. Has anybody done that one with patients? Yeah, so you're just you got to have a stopwatch, you have to have a chair, You're asking the patient to go from sit to stand, and they're doing this without upper extremity support. How many times can they go from sit to stand within 30 seconds? And you'll see the average scores for just the norms. So these aren't for a particular diagnosis or anything. For someone ages 60 to 64, a woman should be able to do at least 12 or more, a man should be able to do at least 14 or more. So it gives you an idea. There may be some literature for certain diagnoses on some norms for this, so that might be something to do a lit review for. But it's a great, simple test that would be able to measure mobility. And if they can't do a sit to stand without upper extremity support, then it's a 0, and that's the score, and you start working on those pieces. 4-stage balance test. Has anybody done 4-stage balance test? Yeah, I like this one, and I use this as treatment a lot too. So this is a test for me, as well as I will use it for treatment. What you're doing is you're looking for an older adult to be able to hold that tandem stance. So they have to be able to get what we would look at on the screen as position 3, tandem stance, and hold that for at least 10 seconds. If they cannot hold that for at least 10 seconds, then they are at increased risk for falls. So it's a quick screen that you can look at. If they can't do tandem and you want to see, can they do semi-tandem, and just measure that and make a note of that and then start working towards that. But then this can actually serve as one of your treatment strategies. So many times I'll have patients, like today, I had a patient who could do semi-tandem stand. He does really pretty well with that as long as he's looking straight ahead, but then we added in head turns. So look right for 2 counts, look to the middle for 2 counts, look to the left for 2 counts while he's in semi-tandem stance. And that got some ankle strategies and some hip strategies going. So that was a good place to work. And then do you guys have an AirX pad that you can like take with you or whatever? Like those little foam pads or something to stand on? Probably not. So you probably don't want to stand on the pillow, but if you got a cushy surface that you can stand on, then you can make it even harder. When we went to tandem stance today, all he could do was look straight ahead. He wasn't able to do head turns right, middle, and left with tandem stance. We did add eyes closed with tandem stance for 3 counts. So, and then this is the picture that I print out, and I write those instructions and have them put it by their sink so that they do it several times a day with being able to hold to the sink as needed for balance, because the sink isn't going to move. It's a nice place to do some balance work, and that's available in the room. Any questions on 30-second chair or 4-stage balance? And I honestly don't do 30-second chair very much. I should, but I don't. Timed up and go. Has anybody in here not done a timed up and go, or anybody at Good Sam not done a timed up and go? At K&I, when we did this presentation, I had a med student who was an actor. This is so fun. Did you know you guys could do that when you were students? I didn't know that was a thing. I could have totally done that as a pre-PT student. We need to get the pre-PT students in on that gig. But they hire them to like portray different diagnoses and stuff. So he was my actor, so he did all the outcome measures. But timed up and go, very simple to set up. Again, I don't know in the inpatient setting exactly what your parameters would be. If there's a particular hallway that you can put little pieces of tape. I get very sneaky because we technically, don't tell Tracy this, we technically can't put tape on the floor or marks on the floor, but I don't want to measure my timed up and go every single time. So our floors are dark, so I have a black Sharpie marker that I have marked these teeny tiny lines that Tracy doesn't see, my boss. I love her, she's the best. But she doesn't know that those marks are there. But they're just, I know approximately where they are. Is she here? I know approximately where those marks are, and I have these, she bought me these great strips that, they're just, gosh, they're like little carpet strips almost. They're rubberized strips though, that I can just plop down over those lines, and boom, it takes me 2 seconds to set up my timed up and go, or 2 seconds to set up my 20-foot walk. So I don't know if you go ahead and you measure a typical room, or if you have like from room to room you know is 10 feet or you know is 15 feet. Just some idea, but that's kind of how I cheat. I have little marks, and then but nobody can see them except me. All right, and sometimes I lose my marks, and that's kind of, I'm like staring at the floor, and they're like, what are you looking for? I'm like, nothing. All right, so timed up and go, we've got a chair, and the chair can have arms. You ask the patient to, when I say go, I want you to stand up. I want you to walk 10 feet to this line. I usually have a line. Turn around, come back, and sit down. And I tell them the timer will start when I say go, and it won't stop until they sit down again, because most of the time my patients will do this. They'll do a great job at the timed up and go until they get to the chair, back to the chair, and then they just stand there and look at me. And I'm like, turn, sit. the timer's still going. So usually I give them a practice run to make sure that they've got the gist of it down, and then I time the second one. The second one's always better anyways. But it's a great measurement of mobility because you're looking at sit to stand, you're looking at walking, turns, and then stand to sit. So I love the timed up and go. I'm not sure if there's a modified version for shorter spaces, but that might be something to look at in some way that you could do that. I've listed on the PowerPoint and in the handouts, and you guys will get access to the PowerPoint and handouts. I'm sorry, I don't have those for you already today, but these are the cutoff scores for different populations. So you've got your community dwelling adults, which is usually the cutoff score that I just use for most people. I'm just by and large, I'm looking at 13 seconds. If it's more than 13 seconds, then I'm considering them a higher fall risk. You've got some data there for older stroke patients, Parkinson's, vestibular disorders, so whatever population you treat, you can find that. And these measures, you can find all of these measures and the detailed information on rehabmeasures.org. All right, the other one, I think we talked about at KNI, but isn't on here, that we use a lot is the dynamic gait index or the functional gait assessment. And again, you may not have the time or the space to do that whole assessment, but if you take a look at that test, there's some cool things in that test. You only need 20 feet of space to do the walking path. And you can just time the patient, like if you use the functional gait assessment, you can time how long it takes for them to walk 20 feet. And they'll tell you if it's 5.5 seconds or less, they're good. If it's more than 7 seconds, that's a moderate impairment, versus if it's really slow, lots of gait variation, that's a severe impairment. That's one piece that you could pull from the FGA that might give you some information and some solid outcome. Also, I like the functional gait assessment better than the dynamic gait, just because FGA includes walking backwards, walking with eyes closed, and walking tandem. The dynamic gait does include walking around an obstacle like a figure 8, but I do like capturing the walking backwards and the tandem walking for my patients. But again, even if you can't use the whole test because of time or space limitations, looking at components of the dynamic gait and or the FGA and kind of pulling that and saying, okay, consistently with this type of patient that I see, I'm going to try and measure this. And being able to use that with that patient at eval, reassessment, and discharge could be useful information, as well as help maybe plan your treatment. So the next steps, when you find somebody, an outpatient, when we find somebody that is at risk for falls, what we're wanting to happen, what we're seeing happen at KNI is we want them to get them to therapy. So the nice thing about being inpatient is you guys are in there already. So you are the ones identifying them for fall risk. And so looking at different balance treatment strategies and what you're going to do, as well as when they're ready for discharge. And I think it's really important to talk to the patient about how important balance treatment is once they leave, ongoing balance treatment. And to be able to find a therapist, outpatient therapy, or home health that will actually assess and treat the balance. So, you know, that doesn't always happen if they go to maybe a clinic that doesn't usually see balance patients. That clinic may focus more on strengthening and flexibility and kind of not even look at the balance component. Or if they go with a home health company, again, that doesn't see a lot of neuro patients, that could be, you know, they might be better off going with, say, can I say this? They might be better off with, say, you know, some place like Cardinal Hill Home Health where the therapists are really familiar with neurodiagnoses versus a different home health company that maybe doesn't have a therapist on staff. I have several friends that are at different home health companies, and so we'll try to, if I've got a patient that suddenly needs to go to home health, but I know they need some Parkinson's specific treatment or they need balance, then I will call Sheila and say, you know, can Jativa pick up this patient? Can they be sure to get you or get one of your friends that feels comfortable treating this diagnosis? Or I'll send a referral for Cardinal Hill Home Health, just trying to get the patient the best treatment possible. So that's just something to think about and talk to about the patient. Most patients don't know that there's a difference in therapists. They don't know that, like, they shouldn't come to see me for a back or neck problem. You know, I don't know what to do. I can't. So they need to see a good orthopedic therapist. But they need a specialist, or they need someone who's at least familiar with those balance to do those balance assessments. Right now what's happening is Kay and I will send these patients to me for a falls assessment, and guess what? These patients live 2 hours away. So I am charged with then talking to a clinic in that patient's home community and saying, this is what we need, this is what the patient's balance scores are, do you feel comfortable with treating balance? Is it okay if we consult and you guys do the same balance assessments that we did today in a month after you treat them and see if we're on the same track, and we'll be a resource for you? Which is adding a little bit to the workload for me, but that's fine, because if we can get the neuro component in these rural communities and we can be a part, UK can be a part of doing that, then that's great. So it's working out really well. We've actually gotten 3 different facilities that have now gone for LSVT big training because of patients that we've sent them, and so I feel like we're building a little bit of a neuro network. But I feel like that's part of our responsibility as PTs and inpatient, rehab, and outpatient, is where are our patients going after they leave us, and are they going to get the services they need? Because you know if they're in Lexington, they're probably going to be fine. If they're in Louisville, they're probably going to be fine. But you go 30 minutes outside, and we may not have the resources we need. So let's work with those PTs in those rural communities and start building that network so that the patients get what they need. There are community-based programs for balance, such as Stepping On. The YMCA has a Moving for Better Balance. Simply the Silver Sneakers class is great, so getting them involved in some kind of community program. There is a Matter of Balance class series. Usually those go through the co-op of that location. So if you frequently have patients from a certain demographic area and you might be interested to see what's offered in that area, that could be if you have a student. PT Students Administrative Project, this is a great project for them. What resources are available in this particular community, say Gary County? What services do their co-op extension offices offer regarding balance and falls? And help us, and we can all work together and help build this neuro balance network. It would be awesome. And again, we want them to have a physical therapy referral specifically for balance and gait evaluation and treatment. And that's what we're trying to get on the orders so that the PTs know we need that balance assessment and that we can follow that through. So you guys know with the PT assessment, we're looking at their history, recent falls, near falls, fear of falling. Posture is a big key for a lot of our patients. You know, the more forward the posture, the more their center of gravity is forward, the more likely they are to fall. So it may be that we need to work a lot on some postural stuff, and that could be something that we work on in the inpatient setting with them while we're working on some other things with the mobility. We're going to look at strength and range of motion. Do they need an assistive device? Do they have the appropriate footwear? Okay, I had this patient last year who always wore flip-flops. She fell every week. She loved her flip-flops though. She loved flip-flops so much that she had a golden charm on her necklace that was a flip-flop. Because every week I'd be like, what were you wearing when you fell? It was the flip-flops. I tripped over them because they don't provide any support. She would trip over the toe. I love flip-flops, but I hate them for my patients. She loved them. I mean, a charm on her necklace. She loved them so much. And so we had to keep doing education about proper footwear and decreased falls. Her daughter bought her some tennis shoes, and she didn't like them, but she did see that there was a significant reduction in falls when she wore the tennis shoes versus the flip-flops. So talking to and looking at appropriate footwear for your patients, looking at their function, their ADLs, what do they tend to do? Is there something that they do during the day that always seems to trip them up, or is there an area in the house that seems to cause an issue? Because you could look at how you could compensate for that or how you could train for that in the clinic. Are they having pain? Pain can be a limiting factor in terms of their mobility, keeps them from moving, gets that whole vicious cycle going, as well as a home safety assessment. You guys don't have the luxury, and I don't have the luxury of doing that home safety assessment because we're stuck where we're at. That's one thing I'm always a little jealous of, people who do home health, because that is the best functional place to work with the patient in the home. But I don't want to be on the road all day. But I will have patients either tell me about things. Do they have stairs going into the house? Is there a rail? And if there's not, can they put a rail? If they can't, can we work on stepping up, stepping down, and working on their balance? Throw rugs, we got to get those up. We got to do education about that. Other things with the home safety is the furniture placement may be completely crazy for the patient. Lots of patients will say, I can't walk with a walker at home because the house is too cluttered. that's a problem. So we have to talk to them, maybe get somebody in the home to help them out with that, either to move furniture or clear the path so that they can safely use their walker. All right, here we talk about some other outcome measures for balance and gait. The Berg, has everybody used the Berg? Y'all did it in PT school. The Berg is like the gold standard. When it comes down, some people look at the Berg and look at the Tonetti. The Berg is your gold standard measurement. When you look in the research for balance and falls, it's going to be the Berg. And I love the Berg. I've used the Berg and the Tonetti, and I always stick with the Berg. So, pretty simple test. Again, it will give you ideas for what things to work on in your treatment. I believe there's a study, I just now thought of it, or I would have included it, that looked at a modified Berg, and I think it was just the last 6 items on the Berg that you do, and there's a scoring, so that might be something to look at with the time crunch, because your guys are on the move, it's faster paced than what, you know, I get 45 minutes to an hour with my patient, they come to me, it's a lot simpler. You guys, it's a lot different for you all. So if you look at that study, for the Berg balance test that was modified, I believe it was the last 6 items, and there was a score correlation to falls. That might be a way that you could incorporate a balance test with some reliable outcome measures, but not have to do that whole test. We talked about the timed up and go. The ABC scale, is everybody familiar with the ABC scale? So the patient self-assessment questionnaire, even just picking apart a few of those questions to ask during your interview, looking at those things and seeing what things might be a problem for them in their home or in their community and what they might be fearful of being able to do. And the FGA, the functional gait assessment, which I used to use the dynamic gait index, the DGI. I went to a Parkinson's course in 2010, and Dr. Farley, who developed BIG and power training, recommended the FGA over the DGI, and I could see why. It just is a little more detailed. It gives you, like with the walking the 20 feet on the DGI, it's not timed, it's just your assessment of if it's normal or impaired, versus the FGA gives you parameters of 5.5 seconds, 7 seconds, and so it gives you something a little more solid, and I like numbers, so I really love the FGA for looking at balance with actual walking. So you can pull up those measures on rehabmeasures.org and be able to pull those up. I have them too if you want me to send them to you, because I use them every day. I've got them printed out. So again, based on your PT exam and your findings, that's where you say, okay, you're 42 out of 56 on the Berg, or you've done the modified Berg, you've been able to do a timed up and go, and they're like a minute and 20 seconds on the timed up and go, so you know what kind of things that you've got to work on. We've got to look at range of motion, strength, and postural deficits, and look at the assisted device, and starting a home exercise program that not only includes the strengthening component, but also includes some sort of balance. That 4-stage balance test, that picture, I probably give that picture out 4 or 5 times a day for patients and mark which I put feet in position 1, stand near the sink, turn your head, or do eyes closed, or something. I might change it up a little bit. I kind of have it in the computer, so all I have to do is tweak a couple of things and print it out. But that's probably my go-to balance, initiating the home exercise program. That's it. Because most everybody needs some help with that component. And then keep going with developing that home exercise program, as well as educating them regarding falls prevention and home safety. On the CDC website, the study, you can go to that and print out patient safety brochures, patient information on balance and falls risk. You can print out a home safety assessment checklist that you can give to the patient, and they can do a self-assessment, or the case manager can do that with them. That could be a great resource, and it's all free. So, good resource. Again, we want to do a patient-centered approach. So I know what I want to work on, and I know what I think they need, but what does the patient think they need? And what's meaningful and motivating to the patient. That's what it all comes down to. So I need to know what their goals are, as well as I need to know what their support system is. And that's huge for you guys, right? Because where they're going home to, and who they'll have to help them makes a big difference in what you're going to recommend that they work on. It may be that I really want someone to be able to do, for example, the LSVT big exercises, because it's going to work on their balance, big movements, and so forth. But they absolutely cannot do that without someone there to assist. If they don't have the support system or the ability to complete that, even though I think that's the best thing, I'm going to have to switch gears and I'm going to have to figure out something a little bit different for that patient, because knowing their support system isn't there, I'm going to have to figure out a way for them to move big, work on their balance by themselves in a safe way. So keep that in mind. So here's the big question. What's the most effective treatment for balance and gait? There's not one. It just depends on what's going on with the patient, and that's where the outcome measures can really help. Is it a visual or vestibular issue? If it is, then, so say the patient can stand with their feet together, eyes open, and they're perfectly fine. They close their eyes, they fall over. They're very visually reliant on their balance. That's where we've got to work on exercises for that. If their ankles are weak, really weak, they need to work on ankle strategies. Then we need to work on exercises that are going to trigger that and help build up their ankle strength and ankle strategies. If it's, say you've got a patient with Parkinson's and it's small shuffling steps, and that's what leads them to start that festinating gait and not be able to stop, then we need to work on big movements. We need to work on posture. We need to work on stepping over items and trying to retrain their system to move big and take bigger steps. So obstacles, putting pieces of paper, Post-it notes on the floor for them to step over, those kind of things. If it's postural, it may be that we need to do thoracic extension type exercises, and that could be done lying down, it could be done with the doorway stretch, it could be done like seated in the chair like you guys are now, and put your hands behind your head and extend back. That's a great thoracic extension exercise that you can do in the room with them. So it just depends on what the problem is with their balance, what the problem is with their gait. Their walking may be great as long as they are walking in a straight line and not talking to anybody. But as soon as they turn their head, they're gone. So it may be that your treatment strategy is to work on walking with head turns. Post-it notes along the hallway, so you have them call out numbers or put cards up on the hallway, or ask them to name off the room numbers as they walk by. Just you have to figure out what the problem is with the balance and the walking, and then hone in on that specific thing. But there's lots of things to choose from. Are you all familiar with balance wear? Has anyone not heard of it? Okay. So balance wear is another thing. I don't know that it's something that you would use necessarily in inpatient, because the goal is for the patient to have a vest to wear at home. But just know that that is a treatment strategy, and there's several therapists in Lexington that are trained in fitting balance wear. I'm trained at UK. There's 2 therapists at Baptist Outpatient, and there's 2 therapists at Kentucky One that are all trained in fitting the balance wear. I don't think there's anyone trained anymore at Cardinal Hill, because I think with Jessica leaving, I don't think there's anybody else there.
Linda's still there.
Linda can do it. So you've got an OT at Cardinal Hill that can fit it. Basically, if you can find a directional loss of balance. So how many of our patients, when they're standing, they always lose their balance back and to the right or back and to the left? There's a definite directional component. Or you have a patient that says, I always fall backwards, straight back, or I always fall to my left side. The thought is, if we can find that directional loss of balance, we should be able to fix it. And probably about 80% of the time we can fix it by strategically weighting this vest with small weights, 1/8 of a pound, 1/4 of a pound, or 1/2 of a pound, to a vest that where the weights are on the inside of that vest, they zip it up. It's just like, so people are like, how does it work? I don't really know. I think it's like a sensory input. They're doing some studies with that right now. But you know how if your patient is like really leaning over to the right or falling to the right, and you give them like a little directional cue, tactile cue to come over to the left, that's kind of how I think it works. I think it's a sensory proprioceptive issue. That weight is giving their trunk just a little bit more sensory input to come to that side a little bit more. The goal is for them to not have to wear that all the time. Get them a home vest, do a wearing schedule so that they get a carryover effect, and then get out of that vest so that they don't have to wear it all the time. I can show you a video at the end. So, just in summary on this, just that falls are not a normal part of aging. Have you all heard your patients say that, or had patients that said their doctor just says, oh well, you're just falling because you're old. This is part of it. Ugh, I know, it's so sad. It's not a normal part of aging. Our balance reactions, our strength, it's all gonna change as we get older. But we can really improve someone's balance with the right exercises and the right type of activity. So we want to identify the falls risk, and you guys are like the first ones to be able to identify that falls risk. And you guys are so important in starting that whole continuum of care, recommending to the physician that when they go home, they really need to go somewhere, or they need to have a therapist that will really work on that balance and gait training. And you can say, we recommend that the therapist does these outcome measures. This is what we did. We recommend that you guys now do these outcome measures, because they may be different, because your patient's going to change. Your patient can change a lot from like day 1 to day 3, right? Which is pretty exciting. So what you do on day 1, they may completely blow it out of the water on day 3, and so now they're ready for the VERG, or they're ready for the FGA. So you can make those recommendations to that case manager, to the physician. We want to do multifactorial approach, include the patient in that conversation. What do they want to work on? What are they fearful of? What do they need to do? Therapy is always going to have more impact and be more successful if the therapy is meaningful and motivating to the patient. So that's what we want to definitely include them on. All right, I will see if I can pull up this video, and you guys can shoot questions at me if you have any questions while I'm pulling this up. Oh, that's going to pull up fast. All right, so I'll just show this to you real quick. You guys can see that one? Okay, good. So this is Terry's progress. She has, I think she has ataxia. This was her start. This was a therapist that's near Philadelphia. He's one of the balance wear instructors, Andy. Andy himself has a balance wear vest because he has MS. She has cerebellar degeneration. So that's how Andy came to learn about it and start offering it in his clinic as a PT. So Terry traveled, to Pennsylvania to see Andy. But you can see how severe her balance is. She cannot control her balance. Notice her posture, and the posterior lean.
She's falling back immediately, and I don't feel comfortable letting go.
So she definitely has a directional component. Now those patients that you have that are every which way, I can't usually fix those with the balance wear vest. I need a directional component. There's a specific evaluation that you do to determine where to place the weights. And so that's what he's done that part. He's placed the weights where he thinks it needs to be. You can see already, this is an immediate improvement. This is same day within a few minutes, which is really fun. So just knowing that this is available for your patients might be, you could refer them or let them know about it. You can print off brochures from the Balance Wear site, and it might be something that they want to try. Especially, I love it for those patients who they don't have a support system at home, so they don't have anybody that can help them do challenging balance exercises to really make their balance better. This is a nice way to give them that safety and security. So this is Terry progressing. I love that she wears a helmet when she's out walking. So that's 2 months post getting her balance wear vest. Her vest is on under her shirt. This is 6 months with the balance wear vest with a patient diagnosed as cerebellar degeneration. I've had stories that have been that successful. I've had some that it's just been minor. But it's one other tool in your tool bag, or at least to know about, so that you can refer people out to that. All right, that's it. You guys got any questions? Yeah.
What's the insurance coverage with the balance wear vest?
Okay, good question. So she asked what the insurance coverage is for the balance wear vest. And so the balance wear vest, there's different models. There's one that has an LSO in it, and some patients really like that. It gives them some more trunk stability. They feel like it helps stabilize them a little bit. My patients with Parkinson's really like that. My patients with ataxia seem to really like that. I would say my patients with MS don't really like the LSO piece. They feel like it's too hot and too binding. Not always, but that's just some of it. You try the vest with the LSO, you try the vest without the LSO. You see which one's better, and there'll be one that's better versus the other. It's not just a comfort issue, but you'll see that they either walk better or balance better with the LSO or not. If they do better with the LSO, which will be sewn into the vest, and they have a patient medical history that includes some sort of spine diagnosis issue, back problem, spinal issue, which many of our patients have, it's billed as an LSO, and it's covered, minus whatever their deductible is. If they don't If they need the LSO but they don't have any qualifying diagnosis for an LSO, then it won't be covered. If they need the vest that does not have the LSO at all, it'll be an out-of-pocket price. When it's covered by insurance, payment can range for their deductibles anywhere from $0 to like $800, just depending on, people's deductibles are so high right now. With our MS population, PD population, their drugs usually within the first few months of the year pretty much take care of that deductible, and so we're ready to not have to pay out of pocket too much. If they need the vest, she has now come up with some lighter weight vests that don't have the LSO. They range anywhere from about $500 to $800 out of pocket for that. So, good question. Yeah.
Will you share the local clinics that you've already collaborated with?
Yeah. I'll try to put a list together. We're actually doing a research study with the PT school. We've got a couple PT students that's their project, and doing a survey and reaching out. So I'll try to gather that information and get that to you. I can send it to Katie, and then she can pass it along. And that would be helpful for you guys to know too. And then if you guys get any clinics or facilities that want to do neuro, I'm trying to go at it as that, like, this is a niche. Neuro is very underserved, and I think of anybody that has balance issue or balance with walking issue as a neuro issue, because they need balance. They don't just need strengthening and just walking up and down the hallway of their home. They need to actually work on walking and talking, or walking and multitasking, and walking in head turns. So I think of that as neuromuscular reeducation, and I'm trying to convince clinics and home health that are in these rural communities that this is a niche. They'll get the referrals if they just get someone that's interested and wants to work, and so far it's been working out pretty well. So I'll try to gather that up for you within the next couple weeks. Any other questions? Any questions with Good Sam? No? Good. All right. Thank you all for coming. Feel free to shoot me an email at any time.